Right. Good afternoon, everyone. My name is Jayaraj Erekkath. I'm one of the internal medicine trainees here in Northern Ireland, and I'm presenting a case report of an unusual neuroglycopenic presentation of insulinoma. And my colleagues are Shivankani Sharma. She's one of the internal medicine trainees in Northern Ireland as well. And Dr. Gautam Das is our consultant. He's an endocrinology consultant, and he's working with Ashford and St. Peter's Hospital in London. So this will be a very short case report, and I hope to finish in 15 minutes. So as an introduction, let's go back to basics. So insulinoma is an insulin secreting tumor of beta cells resulting in hypoglycemia. And it is very common or most common pancreatic endocrine tumor seen in women of age group 30 to 60 years, with an incidence of 4 cases per 1 million patient year. We report a case of insulinoma in a middle-aged woman in whom it took more than a year to diagnose, before which the patient was followed up in various specialist clinics, just because the presentation, the symptoms which the patient came up to us was not completely unique to an insulinoma presentation. That's why it took more than a year to diagnose. Plus, it's not a common tumor we would suspect. So going to the history. So she initially presented to us in January 2017 with these 2 main symptoms: a sudden onset diplopia and anomic aphasia. Both the episodes lasted for nearly 20 minutes each, but a headache persisted. So she presented to ED with these symptoms, and the ECG showed a bradycardia of 45 beats per minute. A CT scan was done to rule out a stroke, and it was normal. Since the symptoms were resolved, the most common thing first, we thought it would be a transient ischemic attack. And in Ashford and St. Peter's Hospital, we do run a TIA clinic. The patient would be seen in a week of referral. That's why we referred her to a TIA clinic. So this was end of January 2017, and by start of February 2017, she was seen in TIA clinic. Since her symptoms were followed by a persistent headache, she was diagnosed as migraine. It was a provisional diagnosis, obviously. Her carotid Doppler was normal, and she had no other risk factors to say she would have had a stroke, but we've diagnosed it as migraine. Then Mobit's type 1 heart block was found on 24-hour Holter monitor, just because she had a bradycardia of 45 beats per minute when she presented initially. Hence, she was referred to cardiology. While she was waiting for a cardiology outpatient follow-up, she presented to ophthalmology due to further episodes of diplopia lasting roughly around 10 minutes, multiple episodes, but ophthalmology couldn't find an organic cause for her presentation, and they discharged her. Eventually, she got reviewed in the cardiology outpatient unit, where loop recorder or a reveal device was inserted because of the bradycardia, and the cardiologist thought it could be bradycardia-induced neurological aura, which the patient was suffering from. Her echo was normal. By now, in 5 months' time, she have had a total of 4 vacant episodes, and which was associated with confusion and amnesia of the events. When asked, she had no clue she had these symptoms, or she was confused for a couple of minutes. So that we call it amnesia of the events. And by October 2017, while one of the neurology outpatient follow-up clinics, she again had multiple episodes over from the month of January till October. The neurology did an EEG, which showed bizarre runs of high amplitude, mixed frequency activity, but no epileptiform activity was identified. But anyways, the neurology outpatient clinic asked her husband to record the videos when she gets the symptoms, which confirmed there were episodes when she was confused, but no obvious adrenergic or convulsive symptoms. Hence, neurology diagnosed her to be suffering from possible confusional migraine with aura to cover for an additional epileptiform activity and to stabilize the electrical activity in the brain. The neurology started on sodium valproate preventionally. Now, we are moving to February 2018. So she has been followed up in neurology clinic regularly with no final diagnosis. But by 2018 February, neurology picked up a couple of episodes when patient developed this confusional or TIA-like symptoms, and paramedics went to her place and looked for or tested for blood sugar, and she was found to have very low blood sugars in a couple of episodes. But obviously she didn't go to the hospital because she was treated with glucose or sugary drinks then, and she stayed back at home. But the paramedics and the neurology outpatient clinic asked her where to keep a diary of her blood sugar levels on a daily basis and when she gets the symptoms. And it was found that her blood sugar at some points were as low as 1.9 millimoles per liter, which is too low. And she was referred to endocrinology clinic by the neurology. While waiting for the endocrinology clinic outpatient appointment, she presented to the emergency department with a collapse. And the emergency department did a CT abdomen and pelvis with a contrast, which showed a 10 by 9 millimeter peripherally enhancing lesion in the tail of pancreas. And the provisional diagnosis was could be a neuroendocrine tumor. And she was immediately referred to a HPV multidisciplinary team meeting, and they advised for a biopsy and an endocrine referral. So here is the scan, and if you could look at the red arrow, so this was the tumor, this is a scan in arterial phase with contrast, and this was suggestive of a neuroendocrine tumor. Hence, the referral was done for HPV multidisciplinary team meeting. And so the surgeons went and did the biopsy. And to mention this, the biopsy was done blindly. Generally, if you're suspecting a neuroendocrine tumor, especially insulinoma, we prefer to go for an ultrasound guided biopsy in order to prevent the seeding of malignant or benign cells. But we had no clue whether it was an insulinoma or not, but biopsy was performed with the histology, and histochemistry showed no evidence of neuroendocrine markers. And her tumor marker alpha fetoprotein was slightly raised with the insulin growth factor normal, and rest all tumor markers were normal. And we did tests for 24-hour urine meta-adrenalins as well, which were all normal. And in April 2018, there comes the final couple of investigations that narrowed the differential diagnosis, and we got a final diagnosis as well. She was tested for short Snackton test to look for her adrenal function, which was normal. And the main test was 72-hour fasting, which started with a glucose of 7.1 in the morning and ended at midnight with 2.3. It is normally done in a hospital setting with monitoring. And her insulin was found to be 141 picomoles per liter when her blood sugar was 2.3, and her C-peptide was 706, and beta-hydroxybutyrate was 40, and she was tested negative for sulfonylurea and insulin antibodies. So we test these to rule out whether it is induced by excessive insulin administration or sulfonylurea administration. And the C-peptide is again gives us a clue whether it's from an sulfonylurea administration or insulin administration, or it is an insulin disorder secondary to an increased insulin secretion in the body. After we got a diagnosis, so 72-hour is the main, 72-hour insulin monitoring was the main test for insulinoma. And by May 2018, she was obviously diagnosed as insulinoma, and she was started on thiazoxide, which is one of the medical management. The action of thiazoxide is it inhibits the insulin secretion from the beta cells by opening up the potassium channels, and the effect is reversible. So once stopped, you get back to the insulin secretion by the beta cells. So thiazoxide helps us to buy some time from patient being referred to surgery and from the date of surgery. So she was started on that and she remained asymptomatic, and we referred her to Charing Cross Hospital in London for a definite management, which was surgery. By July 2018, she underwent a laparoscopic distal pancreatectomy. It was a spleen preserving operation, which was performed with no complications after that. And we could extract a tumor of 1 centimeter in diameter with no local invasion or metastatic disease was identified. And the Ki-67 score was less than 5%. Ki-67 score is something we use for neuroendocrine tumor for grading purpose. So less than 5% falls in grade 1 to grade 2, with less chance of being malignant or severe. Anyways, it confirmed there was not any metastatic disease. Following the surgery, she was initially followed up on a monthly basis for symptom monitoring. And then after 6 months, her follow-up was reduced to once in 6 months. And now she's being followed once in every year. The last follow-up in a hospital was in April 2021, and she remained asymptomatic till then, and she's due for her next follow-up in April 2022. So a quick discussion of what is insulinoma and how does it present, and the most common ways of diagnosing it, and what is the definite management. So as I told you before, our patient presented to us with confusion and amnesia of hypoglycemic event. These are neuroglycopenic symptoms. And generally patients initially present to us with activation of sympathoadrenal system symptoms, which could be palpitations, tremulescence, or diaphoresis. But our patient didn't. We feel that insulinoma had been going on for a while and patient must have developed a tolerance. So she could mask, or she must have masked these palpitations and diaphoresis, but she presented to us with neuroglycopenic symptoms directly. The diagnosis, as we saw it in our case, so the low blood glucose, multiple episodes of low blood glucose reported by the patient with elevated insulin and elevated proinsulin and elevated C-peptide levels in 72-hour fasting. In medical imaging, we recommend CT or MRI scan or endoscopy guided ultrasound to confirm or to extract the cells for histochemistry. Initially, if if the tumor, if we need to buy some time from referral to surgery, we can start on diazoxide, beta blockers for palpitations, and steroids, as steroids has got glucogenic effect and insulin antagonizing effect, and somatostatin analogs. And in cases of metastatic or malignant insulinomas, we can use everolimus, which is a rapamycin analog. It has got an effect on beta cells and peripheral insulin sensitivity, and being studied extensively these days, but we don't know what exactly is the action for rapamycin analogs like everolimus, but these are used in patients who are not ideal for us or are not a surgical candidate of malignant insulinoma. And surgery is the first choice, and it is curative in vast majority of patients, like in our patient. So as a conclusion, most insulinomas are sporadic and urgent commonly, and 90% of all insulinomas are benign. Insulinoma being a rare tumor should not be overlooked. Involvement of various specialties, as we saw, endocrinology, internal medicine, surgery, pathology, medical imaging, and oncology are inevitable in timely diagnosis and treatment of insulinoma. So I would like to express my special thanks to endocrinology consultant, Dr. Das, who works for Ashford and St. Peter's Hospital in London, and my colleague, Shivankini Sharma, to help me with collection of data and presenting this as an oral presentation in here. And these were the references we used. So that's all for today from the case report. So if there is any questions, I'm happy to answer.